Hello dear students, so today I am going to discuss about the topic ulcer. So what is ulcer? Ulcer, that word means a break on the skin or on the lining of the organ, or you can say the lining on the surface of a tissue. That is, in short, we can say that it is basically the breakage. So you can see in this picture a sore formation on the surface of the stomach is formed. So that is the cause of ulcer, or we can say that that is a formation of ulcer. So here in this PPT I am going to discuss about the various drugs that I am going to use to treat ulcer. So the four classifications, that is the first one that inhibits the gastric acid secretion. Now gastric acid, as it has an acidic pH, it causes the sore. So what I have to do, I have to reduce the acidic pH. So on that the drugs are going to act upon. Second is the drugs that neutralize the gastric acid. Most commonly we can say the antacids. The name itself can tell you that it is anti-acid. Third is the ulcer protectives, and fourth is the anti-Helicobacter pylori drugs. Helicobacter pylori is the causative agent that mainly causes the ulcer. Now for the mechanism of action for H2 antagonist. How they are acting? They are acting competitively. Competitively means they are directly blocking the H2 receptors. Now where these H2 receptors are present? They are present on the parietal cell that reduces the gastric acid production. So while they are reducing the gastric acid production, so automatically the sore formation, the crater formation on the walls are reduced. So drugs are acting upon them. It also helps to reduce the acid secretion stimulated by acetylcholine, gastrin, or any dietary elements. Now the various uses of H2 antagonists. So here you can see the various names of ulcer mentioned. So like duodenal ulcer, gastric ulcer, then various stress-induced ulcer, gastritis, GERD, Zollinger-Ellison syndrome, prophylaxis. So here the H2 antagonists are mainly in use. So as we are using drugs, definitely there will be some side effects, and prolonged use may cause adverse effects. So here in the bullet points for the adverse effects of the H2 antagonist, we can see that headache, dizziness, bowel upset, in case of CNS, confusion, restlessness, then different types of heart problems like bradycardia, arrhythmia, cardiac arrest. All these adverse effects can be seen on the prolonged use of H2 antagonist. Next is the very common drug that we often use, that is the PPIs, that is proton pump inhibitor. Now the common name that is very commonly heard in the marketed drugs like omeprazole, pantoprazole. You can see prazole is the ending tail of the drug. So prazole drugs, you can remember, is at PPIs. Now let's look into the mechanism of action. What they are doing? They are basically the prodrug. Now what is the concept of prodrug? Prodrug is the inactive form of drug that is converted to active form. Now how these prodrugs are acting? They are acting by neutralizing the pH or reducing the pH. And how it is occurring? It inhibits or it reduces the gastric mucosal carbonic anhydrase. Now what is this gastric mucosal carbonic anhydrase? It is basically the gastric acid which is secreted by the parietal cell. That pump is being inhibited. So if we can inhibit that pump, what happens? The gastric acid or acid secretion is reduced. So what it is inactivating? It is inactivating the H plus K plus ATPase pump and thereby reducing the acidic environment. Next is the pharmacokinetics of the proton pump inhibitor. Now kinetics itself means how the drug is moving in our body. So we can recall, if we go back to the initial, that is the ADME. That is absorption, distribution, metabolism and excretion. So how long a proton pump travels in our body? So basically their form of availability is enteric coated drugs, and they should be given at 30 minutes to 1 hour before your meal consumption. Usually the half-life of these drugs are very short and it lasts around 1 to 2 hours. Next, the action of these drugs, they can remain or they can show their action for at least 24 to 48 hours on single administration of the dose. And after 3 to 4 days of the continuous administration of the drug, you can see a very positive result in this gastric acid secretion. And if you are a chronic ulcer patient, you can find that you are getting a preliminary relief out of it, because a chronic patient requires a regimen of treatment, so that should be taken care of by a medical practitioner. But for a basic patient who is having acidity or anything indigestion kind of problem, for them it can be a very good relief on the administration after 3 to 4 days. Then comes the therapeutic uses of the PPIs, that is gastric ulcer, bleeding of ulcer, Zollinger-Ellison, then recurrence of the NSAIDs. Now what are NSAIDs? They are the non-steroidal anti-inflammatory drug, and prolonged use of these NSAIDs, they also cause ulceration. So the prevention or the preventive use of these NSAIDs are also one of the measures we can take to reduce this ulcer. Next is the GERD, that is the gastroesophageal reflux disease. So there also the proton pump inhibitors are used. So the following diseases you can cite as an example as a proton pump inhibitor as a choice of drug. Adverse effect for prolonged use, it causes nausea, loose stools, headache, abdominal pain, constipation, joint pains, dizziness, rashes, and there are other rare diseases also occurs as a adverse effect of the proton pump inhibitors. That is gynecomastia, erectile dysfunction, leukopenia, hepatic dysfunction, osteoporosis, especially in case of geriatric patients, and hypergastриnemia. So these are the rare diseases you can find when the drug, that is PPI, is used for a longer time. So as a summary, I can say they reduces the gastric acid, they also enhance the local production of mucus or the bicarbonate, and also they help to maintain the mucosal blood. Now the therapeutic use of misoprostol, you can see here, is the NSAID induced mucosal injury in case the misoprostols are used. So similarly you can say that in case of PPIs and misoprostol as well, all the objective is centrally focused, that is they reduce the gastric acid secretion. Next is the antacids. They are basically the weak bases. So what they do, they neutralize the acid or they inhibit the formation of the pepsin. Why? Because pepsin is forming an acidic pH environment. So that need to be reduced. Now this acid neutralizing capacity, who is providing it? That is the antacids. So they are showing the potency or their therapeutic effect of the drug. Now the type of antacids, first type is the systemic antacids. Very commonly used, that is sodium bicarbonate. So they have a potent neutralizing capacity, they can be used instantly, but there are several demerits as well. They may cause alkalosis, they may cause distension, they may cause rebound acidity, sodium overload. So these are the demerits, but as a systemic antacid, a very good choice is sodium bicarbonate. Next is the non-systemic antacid. They are basically insoluble and poorly absorbed, and they are the basic compound as previously said. So what they are doing, the chloride ion that is reacting with the intestinal HCO3 minus ion, and that HCO3 is not spared for absorption. As a result, the acidic environment is reduced and the healing of ulceration done. In case of non-systemic antacids, magnesium hydroxide is a very good choice. Magnesium trisilicate, aluminum hydroxide are very commonly used non-systemic antacids that is used. Duration of action is usually of these non-systemic antacids are 30 minutes and they show action for about 2 hours. In case of aluminum antacids, adverse effects like constipation is seen in majority of the cases. For magnesium antacids, osmotic diarrhea is also seen. In renal failure, the aluminum antacid, they may cause aluminum toxicity and encephalopathy. So those are the prolonged adverse effects. Aluminum salt or sulfated sucrose, they are the ulcer protective drugs, or you can say sucralfate, the ulcer protective drug. In this case, what happens? In the acidic environment, they polymerize by cross-linking the molecules. Why? To get a viscous gel-like formation that is adhering to the wall of the ulcer crater or the ulcer sole, and that helps in reducing the duodenal ulcer. Thereby, it helps to reduce the ulcer, protects the ulcer and forms a layer that adheres to the walls of the esophagus, stomach or the lining where the ulceration is formed. They also show the astringent action which is acting as a physical barrier, and the dietary proteins are also deposited in this layer to form another coat. So dear students, for today's class, that's all we discussed about the drugs and how the drugs are used for the treatment of the ulcer. So in the next class, I will be discussing about the classification and the examples of the drugs that are mainly used for the treatment of ulcer. Thank you. Hope you all stay well. Take care.